Good morning. I'm really honored to be here. Thank you so much for inviting me. I was given two talks, so I'm speaking also tomorrow, and I tried to come up with how best to start the conversation about other potential comorbid diagnoses that can present with a CSF leak patient. And I thought it best for today, at least, to sort of describe one of my complex patients, because I see a lot of complex patients with a lot of different diagnoses that can sometimes obscure the CSF leak. But I realized after hearing these fabulous talks before me, that I probably didn't have to do that because they basically describe these patients. And so, this talk just describes another complex patient, frankly. And then tomorrow, I plan to go into some of the different diagnoses that can explain some of the varied symptoms and some of the obscure symptoms that patients will present with that may not be a CSF leak or might actually be due to a CSF leak. So I apologize for the repetitive nature of this talk compared to the ones that have just been before me, which were excellent, by the way. And so how do I control this like this? So no disclosure conflicts. So this was a patient, and I have a whole practice of chronic and complex patients. And so it's not a practice of CSF leaks. It's not a headache practice. It's just chronic and complex kind of patients that have all kinds of different concerns. And so this was a 37-year-old male who was referred to me because of refractory migraines, actually, was the specific reason for the referral. But he also had chronic fatigue, and he described a lot of different types of headaches that were not migraines, didn't meet criteria for migraines, but he was described as having refractory migraines, and he'd had them for 5 years. And every time I see a patient who's had refractory headaches for 5 years and have already been tried on just about everything we do for migraines these days, I can't help but think of the anatomy, that the anatomy is playing a role. He was unable to remain upright for any length of time, which meant that it really impacted his daily life. He couldn't play with his kids. He couldn't be in the kitchen preparing his meals. He couldn't be at the sink brushing his teeth. He couldn't go for walks. He couldn't do his job. So it really impacted his life, and he had poor quality of life, and it was impacting his family life. And so he was very depressed when he saw me. And I would ask, patients often will say, I just can't be upright. And so I think it's an important question to ask, well, what happens when you are upright? What happens immediately when you're upright? What happens an hour later, 5 hours later, and so on? Usually they're not upright for that long of a period, but I like to know specifically what they're feeling. And so he would say that he would develop a headache. He would feel his heart racing, that he felt that he had bone pain and muscle pain, that he would occasionally say that while he was standing, he would go through paroxysmal episodes of weakness. He definitely described tinnitus, and I asked, was it with your pulse? He said yes. He had blurry vision, nausea, occasional vomiting with the nausea, though that wasn't a common complaint. He would flush a lot, and he said that he would flush even when he was lying down, so it wasn't specific to when he stands, but he would definitely flush often. He had what he would refer to as his nose would leak, and he had lots of abdominal and pelvic pain, but mostly would say lower abdominal. It was clearly in his pelvis. And interestingly, he often described, along with his headaches, he had neck pain that restricted his range of motion, so he couldn't look around the room. He had young kids, and he felt that that was really a concern because he had to always make sure that his kids were safe, and he would describe certain scenarios where he had to abruptly turn his head, and then he would have an abrupt onset of very severe symptoms that included radiation of pain from his neck down to his shoulders and his upper back and his left arm. In the proximal section. He had a history of allergies, so he had a history of atopy, basically, so allergies, eczema. He had asthma as a diagnosis as a kid, but didn't really have any kind of asthmatic symptoms as an adult, but he definitely had them as a kid, and he still had allergies and some occasional eczema. He had a history of 2 motor vehicle accidents with whiplash injuries, and he also had a history of recurrent infections. So he's a kid, he had lots of ear infections. He said that he had recurrent strep over the years. He was told that he had vector-borne disease, specifically Lyme, and I think it was Bartonella. He did not consider himself hypermobile. He didn't feel he was flexible. In fact, he laughed when I asked him that question. Other symptoms, on a review of symptoms, he had paresthesias, he was short of breath, he definitely felt fatigue, he had insomnia, constipation, and after he ate a meal, he felt really horrible. He said his stomach was distended, and it increased the pain. He had leg pain and he had urinary retention, so he didn't fully evacuate his bladder when he went to the bathroom. His neural exam was normal. He did have a diffuse rash on exam that wasn't eczematous, so it was a different kind of papular rash. He was told it was a contact dermatitis. His Baton score was a 5 out of 9. I still do that in the clinic. I'm not a huge fan of the Baton score, because I don't think it really tells you about the connective tissue of the patient. But regardless, I do it because it is an easy kind of test to do, objective, that you can record on the chart note. It was a 5 out of 9. He did hyperextend his elbows and his knees. He was able to touch the floor without bending his knees. His tilt table test was positive for POTS. His QSART was abnormal. Skin biopsy showed small fiber neuropathy and was positive for synuclein. His labs had an elevated MMP9 and an elevated VEGF. He had normal histamine and tryptase. He did have positive markers for vasculitis. He had an elevated eosinophil, so I followed up with an ECP, which was elevated. And whole genome sequencing showed a variant of SCNA4A. So he was diagnosed with hypermobile EDS. He diagnosed with MCAS. He came to me actually with the diagnosis of MCAS already. He was diagnosed with POTS, orthostatic intolerance, small fiber neuropathy, and eosinophilic vasculitis, idiopathic intracranial hypertension, suspected CCI with IJV compression, possible hypokalemic periodic paralysis. All of these diagnoses, I mean, most of them, I will go into more detail tomorrow, but these were his diagnoses. So we did a bunch of imaging because, again, he was referred to me because he didn't respond to any of the medications for his headaches, and that really was a prominent complaint of his. So I did a brain MRI with and without. There was pachymeningeal enhancement. His cervical spine without, which was done on a separate day, because these were over, I just sort of put together several different visits with this patient. Showed CCI with where the C1 sat. There was suggestion of compression of the internal jugular vein. That was confirmed by a CTA. MR of total spine myelogram was without a leak, without obvious leak. It was read as normal. A CT, a cisternogram, which was ordered by a different doctor, an ENT, actually showed suggestion of leak at sphenoid. An MR of the lumbar spine without contrast showed a tethered cord, and that was read by a different a doctor as well. So we had repair of the cranial leak, which improved symptoms but did not resolve symptoms. His SFT for his tethered cord was successful, but he developed horrible post-op complications that kept him bedbound for months. He had a CSF leak actually at the site of the SFT. He felt worse. He ultimately got better. He retethered, had repeat SFT with a prophylactic patch this time. He felt better, but symptoms still persisted. His ICT, his invasive cervical traction, was positive for pathologic cranial cervical instability. His ICP bolting was with increased pressure readings that were greater when he was lying down versus sitting versus standing, but all were increased. His transcranial Doppler showed low velocities. The patient underwent a C1 shave for decompression of the internal jugular vein compression. Intraoperatively, the surgeon noted what he referred to as a chunky styloid, and that was resected as well during that time. Symptoms further improved. Symptoms postoperatively, though not as severe, returned 3 months later. And he considered the fusion because he had never actually had the surgery for the cranial cervical instability. He'd only had the surgery to correct the internal jugular vein compression, but he did not at that point want any further surgeries, and who can blame him? So he decided to proceed with pharmacological management and other non-surgical kinds of management. These were just a list of the medications that he was on at the most recent visit. We had tried a ton of different medications, and there was a lot of trial and error. Sometimes they would work for a brief period of time and then they would stop working, and sometimes they didn't work at all. He would sometimes have side effects. We'd have to try to compound some meds, but as you know, not all meds can be compounded. He went for injections for the CCI because he really wanted to correct that, because that was sort of the leading thought that was sort of the lead contributor to most of his symptoms. Those injections, don't correct the anatomy, as I always tell patients that. I think that they could sometimes minimize the symptoms by theoretically improving the tone of the ligaments that are holding that joint together, but they don't correct the anatomy. So sometimes patients have some relief following the injections, but he wanted to avoid surgery, so he went for the injections, and they did not help. He did all kinds of other modalities. Ultimately, I did get him approved for IVIG, which did seem to help. He's still on it, but it also plateaued in terms of its benefit. And he also went for several rounds of plasmapheresis. So he improved for 4 months. Symptoms returned. An MR of the total spine of the myelogram, again, showed a leak at T6 to T10. And the reason why I had ordered this at that time, because he came with an additional history of he was moving boxes and then all of a sudden had an acute onset of pain. And then he had symptoms. And so I thought, okay, well, let's see if you popped a leak. So he did. MRV of the abdomen and pelvis around that same time. Again, these were several visits, showed left iliac vein that was compressed by the right iliac artery, so was diagnosed now with May-Turner syndrome. He had a blood patch, no improvement, had a second blood patch. He had improvement. He had improved headache, fatigue. He was able to be upright for longer periods of time, still had some symptoms, but mainly due to the other diagnoses that existed. Continued pharmaceutical management, added mitochondrial protocol, and because I had done a muscle biopsy at this point and had found some problems with his electron transport chain. So we added some mitochondrial support, referred to vascular surgeon for the May-Turner syndrome, and the current plan is stenting. He is currently doing okay. He's continuing to manage all of his comorbid diagnoses, including the IIH and neuroimmune dysregulation, has had flares and has had repeated imaging for leak twice, but no leak identified. And that is that description of that very complex patient. And you can sort of see how this journey goes. It's sort of never this just one, we figure this out. Oh, here's the problem. Let's fix it. And now you're all better and all ready to sort of enjoy life, because that just does not happen in the complex patient population. It's always a lot of monitoring and surveillance and these comorbid diagnoses that often present a lot of the disability that they exist with on a daily basis. And so I think as an overall plan, it's important not only to correct whatever anatomical diagnosis you find, including the CSF leaks if they exist or if you can identify them, but certainly any other of the other non-anatomical diagnoses that really do impact their daily life. So that's the description of the patient. And like I said, I'll go into further detail tomorrow, but I thought that was a good way to start.